I am Dr. Mehmet Akif Buyukbese from Gaziantep City, Turkey. My talk is on type 1 diabetes DAR global survey. When the very first time, actually, Professor Mohammed Hassanin sent me the flyer of the conference, I shared a bunch of my colleagues and friends throughout the country in Turkey. And one of my friends immediately called me from the cell phone and said, "Hey, brother Akif, when are we going to Mecca?" Okay, so these are the outlines of my talk. Many of you are aware of this publication during the time of COVID-19 at Diabetes Research and Clinical Practice, which is the official journal of International Diabetes Federation. And I would like to acknowledge those names. I'm not going to read them of all. Do not worry, but their contributions, these investigators' contribution, without their contribution, we couldn't make this publication perfectly in many parts of the world. So fasting Ramadan is one of the 5 pillars of Islam, and it's obligatory for healthy Muslims, and illnesses and serious medical conditions make them exempt from fasting. However, 2 decades ago, the famous DAR study showed up with 43% of the population is eager to fast despite many complications. And during this 2 decades time, actually, the bunch of studies performed have to fit in, and whom to fast has been a dilemma. But lately, 5 years apart from 2006 and 2021, we had the opportunity to update the guidelines and publish them, both of them, in the Diabetes Research and Clinical Practice. During the time of COVID-19, the study has been carried out, and unfortunately, so far, according to World Health Organization, we have all over the world more than 6 million death casualties, unfortunately. Pandemic represents an additional new concern for type 1 diabetes, and Dr. Hanif and some other investigators reported that the diabetes is a significant risk factor for adverse outcomes of COVID-19. Which is SARS-CoV-2. One epidemiologic study looking into a people with type 1 diabetes by Dr. Al-Abadi, namely DAR-MENA type 1 diabetes study in 2016, included 136 patients' experience. A study from Bangladesh and another one, however, showed that the appropriate patient selection is very important, whether for type 1 diabetes of adolescents or type 1 diabetes of adults, then it will be able to fast. During pandemic, we selected 13 countries, predominantly Muslim population, and the surveyed population of these 13 countries are namely Algeria, Bangladesh, Brunei, Egypt, India, Kingdom of Saudi Arabia, Malaysia, Morocco, Pakistan, Tunisia, Turkey, United Arab Emirates, and the United Kingdom. And people were surveyed during 10 weeks before June and August 2020 and shortly after the end of Ramadan. A brief questionnaire built up actually included whether COVID-19 pandemic affected the decision-making, whether or not to fast, risk of both hypoglycemia and hyperglycemia, the level of education, self-monitoring blood glucose, according to adverse events, whether the patients attended emergency or admission to hospital or cured or not, all recorded. And hypoglycemia is defined as less than 70 milligrams per deciliter. However, significant hyperglycemia is more than 300 milligrams per deciliter. So a total of more than 1,400 people included in the study, and it's been shown that 71% intended to fast, and fairly high numbers. And we see slightly higher female predominance, more than 53%. And when we look at the countries of this fasting population, 60 from Kingdom of Saudi Arabia, 15 from Egypt, 7 from United Arab Emirates, 1.7 from Morocco, and only 0.8 from Turkey. Participants were mostly on basal bolus insulin therapy. Then comes insulin pump and mixed insulin regimen. But if you look at the comparison of the insulin pump, it is 40% higher than the insulin regimens in the surveyed population. This nice table actually summarizes the demographic and clinical characteristics of the study population according to age. Group number 1 is less than 18 years of age, and group number 2 more than 18 years of age. When we look at the total participants in the surveyed group, is triples in the second group, and the same for participants fasted, again triples in the second group. Mean age doubles from 14 to 28. You see in the both of the groups female predominance. Duration of diabetes 6 and 12 years, doubles again here in the second group. Hemoglobin A1C is higher in both of the groups, 9.5 and 8.5, which is higher statistically significantly in the first group, as you see here. While the predominant therapy was basal bolus therapy, it was higher statistically significantly in the first group, as you see here again. When we look at the listed comorbidities and listed comorbidities here, hypertension, hyperlipidemia, microvascular complications, and as well macrovascular complications. And all of these comorbidities were significantly, statistically significantly higher in the second group as a comparison to the first group, which involves less than 18 years of age. Country-wise analysis showed up that the Ramadan fasting for type 1 diabetes ranged from 13% in Turkey to 85% in Malaysia and 90% in Saudi Arabia. Very interestingly, full month observation of Ramadan was around 27%. However, 45% almost observed the Ramadan fasting more than 22% of the time. And in total, you see more than 70% of the population fasted more than most part of the Ramadan. And almost 60% in both of the groups broke their fast due to diabetes-related illnesses. However, while the impact of COVID-19 was not statistically significantly higher, when we compared between the groups, then the statistical significance is observed in the second group, not to fast. This table 2 summarizes some of the questions we ask in both of the groups. One of them is, how many days did you manage fasting? Both of the groups fasted more than 3 weeks. And intention to fast Ramadan this year answered in the first group statistically significantly higher than the second group. Shawwal fasting was observed in both of the groups in quite number, almost 6 days, and it was higher in the second group, again, I have to say. Then the questions come related to hypoglycemia, like daytime hypo or hyperglycemia, and breaking fast due to either hypoglycemia and hyperglycemia. And according to either hypoglycemia and hyperglycemia, attending these adverse effects to hospital or emergency department. The other 2 questions were related to self-monitoring blood glucose and education of Ramadan, which is a structured and Ramadan-dependent education. Figure 1 nicely summarizes the hypoglycemia properties of the study population, is with the colored bars here in the second group, which is higher than as a comparison to the first group, which is less than 18 years. Interestingly, the very first few days of Ramadan observed the highest sky-high number of hypoglycemia as a comparison to the other weeks of the Ramadan fasting, and sharply decreases after the first week and approaches to almost 0 through the end of Ramadan, as you see here. When we look at the time frame once again here, you see the highest number of the hypoglycemia rate is seen between 3 p.m. and Maghrib, which is closer to Iftar. Rates of hypoglycemia is summarized in this slide where you look at 60% participants reported hypoglycemia, and rates of daytime hypoglycemia was not statistically significant between the groups, as you see here. The least hypoglycemic episodes were encountered, by the way, in the study population between 9 a.m. and 12 p.m. Average days of hypoglycemia differed between the groups. In the first group, 6 days, and 5 days, around 5 days in the second group, as you see here. The response to hypoglycemia during Ramadan fasting was either increase of the frequency of monitoring or stoppage of the Ramadan fasting. And in both of the groups, it was around a bit higher than 10%. However, again, 10% of the participants as a reaction to hypoglycemia did nothing. And 9% in the first group and 2% in the second group omitted medications and continued fasting despite hypoglycemia. And breaking of the fast reported by nearly 85 of those with hypoglycemia, I have to say. And there was no statistically significant difference between the groups regarding hypoglycemia. There was no statistically significant difference between the groups regarding hypoglycemia and attending emergency department or hospital admission, as you see here. When we look at hyperglycemia, however, it is less than hypoglycemia, like 45%. And likewise, rates of hyperglycemia was not different between the groups. And again, likewise, hypoglycemia. For hyperglycemia, it's seen mostly in the very first few days of Ramadan fasting. The reaction of hyperglycemia as incidence of hyperglycemia seen mostly in the eating hours, like 45%, and there was no impact of age on the risk of hyperglycemia. There was no significant difference, again, for the duration of hyperglycemia occurrence between the groups statistically. When we look at the reaction to hyperglycemia, we see mostly the dose medication increase 35% of the time, and then comes as a frequency, cut down the food. However, 10% participants in the first, 5% of the participants in the second did nothing as a reaction to hyperglycemia. There was a significant impact of age contrary to hypoglycemia at this time for the breaking of the fast due to hyperglycemia in the second group, as you see here. And likewise, hypoglycemia for hyperglycemia as well. Because of hyperglycemia, there was no difference among the groups regarding emergency service or hospital admission. Ramadan-focused education was around 60% and mostly seen statistically in the higher age group in the second group. And the most of the education was given more than 50% of the time from their doctors rather than other healthcare professionals such as dietitians, nurses, and other professionals. And most of the time it is performed during a routine consultation rather than online application, leaflets, or professional group sessions. And it has been also observed that the 60% of the time checking blood glucose was the same as before Ramadan fasting, such as 3 to 4 times daily. This table 3 has some remarks, such as almost 27% fasted for full 30 days, and there was no symptoms of hypoglycemia for about 40% of the time, and 50% reported no episodes of significant hyperglycemia, which is more than 300 milligrams per deciliter, and more than 90% did not require to attend ER or hospital, either for hypo or hyperglycemia, I have to say. Although the EPIDR study showed up that at least half of the Ramadan observation for type 1 diabetes observed 42% of the time, recent DAR study showed up 72%, and our study is 62% of the time. That means between 1.5 to 2-fold increase in the rate of Ramadan observing for type 1 diabetes for the current time. One other thing is that while much of the focus during Ramadan, especially for type 1 diabetes, is on hypoglycemia, the EPIDIAS study showed up that the hyperglycemia seems to be a significant increase in the rate of hospitalization rather than hypoglycemia. And in our study also, emergency services attended was 8.2%, which is more than those requiring this level of service due to hypoglycemia in the study surveyed population. Structured education in reducing the complication of diabetes is very important, and some participants in the survey reported fasting despite not doing any blood glucose monitoring, which is very important that we have to think about. There are some noteworthy limitations, such as hypoglycemia was reported as symptomatic rather than confirmed, which may give rise to higher rates of hypoglycemia. The other thing is that the survey cohort includes more than 50% of the time from the Gulf and the Gulf region and UK, where medical facilities may be high standards as a comparison to other parts of the world. And one another thing is that maybe the attendance of the emergency department or hospital during COVID-19 may be less because of getting infected with the virus, so that many patients opted home management of hypoglycemia rather than attending to hospital or emergency department. As a conclusion, COVID-19 pandemic had minor impact on decision to fast Ramadan in type 1 diabetes cohort, and this survey highlights the need for Ramadan-focused diabetes education to improve glucose control and prevent complications during Ramadan fasting. This view is from Istanbul, Maiden Tower, and looking from the Asian side to the European side between the continents. My last slide, lower rates of severe hypoglycemia compared to 20 years ago reflects the advances in type 1 diabetes management and better understanding of fasting Ramadan, so that low rates of emergency department attendance or hospitalization for diabetes during Ramadan did occur. Thank you very much. This is Golden Horn, again, Istanbul, and thank you for taking time to listen to me.